cognitive flexibility, it's like a hallmark, isn't it, of resilience, your ability to think, to be uncertain, to tolerate uncertainty, and to think in flexible ways about how to manage it internally and behaviorally in the world. And of course, that's what we all try and do with all our clients in therapy. But this area makes it particularly difficult because of the rigidity and the certainty and all the pressures that come into the room. But I mean, what you're saying is about narratives. So the narrative, the dominant narrative at the moment is that the gender-affirming medical treatments are being taken away due to hate and to persecution. And, you know, all of us here have voiced our concerns with those medications from a place that is not at all associated with hate, quite the opposite. You know, my way of being an ally to this group of kids is to really look at what medicine is being offered to them and what it's doing to them, you know. And when I explain that to the young people that I work with, I say, look, you can disagree with me. You know, please do. We can talk about this. But this is how I got to my position. And I tell the story, you know, and I can talk about how I started off gender affirming, you know, and have gone the whole way to where I am now. And they've all come on that journey with me. Some of them, many of them do disagree with me still, but they're able to tolerate that maybe I'm not, you know, just there to hate them and to persecute them. And I guess that we need those stories to come out of the clinic rooms and to come into society and into societal debate so that there is at least an alternative story about what is happening here. It's very tricky, though, as Roberto said earlier, given the way it's been done, you know, in the States. I think it's a hard sell at the moment.
And I think especially, you know, for those kids that are more traumatized probably and that are more fragile and maybe don't have the capacity to trust or to think in more complex, reflective ways because of what's happened to them. So, yeah, they're probably particularly vulnerable, I think.
How can we reach them?
This kind of loops in with a little bit of what I was preparing in ahead of this talk, but I think that we really have to start with, you know, empathy and not necessarily agreeing with their exact version of the story, but just to hold their extreme distress and their fear and just create, for lack of a better term, just a safe place for them to express that and discharge that. And I often find that when clients are dysregulated, you know, that can come and go, you know, if you just allow it to be. And I think, you know, once the trust is established with a client, I think it's really powerful to say, I know this is really hard, but I think you can get through this because I know you, right? Like once you do know a client, you can say that. So one of the things I was just thinking about, and this is really hard because this is completely, for some of these kids, this is a completely political domain of distress, right? But I think keeping politics out of therapy is very, very important. I think the reason we got into this mess in the first place is the gender-affirming therapy is a political intervention. I think it's like we're going to prioritize this identity above all other psychological concerns, and I think that's political in nature. And so I think it's just really important for us to avoid getting into kind of a back and forth. And I think for sure there has to be some reality testing when you intuit that it's a good place to do so. But I think getting into kind of heated debates around political questions when a person is dysregulated is just not helpful at all. So it's hard because they're probably coming in with all kinds of political complaints and rants. But I think if we can keep politics out of therapy as best as possible, that's really important.
I mean, this is the challenge in this work from the beginning, isn't it? To kind of find a way to connect with the person's distress without colluding with the explanation for the distress, right? And that's kind of what we need to do here too, is really recognize the real terror they're feeling without saying, yeah, this is terrible, what's happening to you and the world is against you. It's a very fine line to navigate.
And it's hard to do. If you're working with that level of distress with a society that's reinforcing the belief about where it's coming from and what the solution, it's really hard to contain that. But we have such an important role in containing it and not triggered into action by it, because everybody else is being triggered to act, right? To do. And actually we need to be with them, you know, through it. And as you say, it comes and goes, it comes and goes. But if we can tolerate it, if we can sit with it and contain it, then we can communicate maybe that they can bear to be with it without being driven to action.
The most liberating point for me in working with kids was the moment when I realized it's not my job to save them and that I can't possibly correct what's going out in the world. And all I can do is, I mean, it really just sounds cliche, but to do what I've always done as a therapist, just be in the room and take a genuine interest in getting to know who this person is. I mean, not to be political. Where I was, I think when I first got in, I think I was quite messianic and political.
Well, affirming is profoundly political, isn't it?
Yeah.
And sort of, if you were to go in and say, well, you're definitely not that, then that's profoundly political. But we're trying to just be normal therapists where we don't know and they don't know and no one knows. And it's hard to do. And it's particularly hard when you've got very young, sometimes profoundly vulnerable young people talking about really very extreme medical options that they're deciding between. It's very difficult to not be very hooked as the adults around that.
Yeah. And I mean, in my experience of doing like some expert witness work and reviewing clinical notes of young people who did transition, what I've noticed is that the clinicians adopt a posture of allowing the young person's distress to lead the pace and direction of treatment, which is so shocking. And especially now in light of these executive orders, I presume many therapists here may have patients who maybe they were kind of coasting along, exploring things, and then all of a sudden they're like, oh, now I have to rush into a medical process. And so it's kind of this fine line between, just being with the client and trying to get to know them as individuals, but also having enough kind of confidence in our authority as therapists not to get swept up in their panic around gender, especially if we have not personally experienced gender dysphoria or we have not, personally had a lot of experience around gender medicine. It's easy to kind of offload the responsibility to the client of like, well, you tell me about that, and I think most of us are here because we don't really want to work in that way, but I suspect that happens a lot. Therapists who feel really incompetent in this particular domain of expertise, they go, okay, well, client knows best, they're trans-identified, they know everything, they came with all this research that they've done or whatever. So I think it's really important for us to also kind of like own our place of authority as a therapist, not necessarily that we know what the client should or shouldn't do.
Just going back to what you were saying, Anna, I think one of the things about working with patients who are experiencing intense psychological distress is that it generates distress in the therapist. And that is the biggest challenge, I think. And I think that's probably what drives the gender-affirming model, is that it's a way to relieve the therapist's anxiety. Like, you can do something about it. I mean, it seems like you're relieving the patient's anxiety, but you're actually relieving your own by, taking this kind of action. And I think you're pointing out too that, we can also do the same thing by trying to reassure and trying to reality test and trying to impose our own political agenda. And it's very difficult to tolerate that anxiety. But I think, it's a communication that tells us just what's going on inside that patient. And we have to tolerate it as much as they do.
Humans experience extreme distress. It's part of life. It's unavoidable. We're all going to be bereaved. We're nearly all going to be traumatized one way or another. And that people who don't have gender-related distress that we work with can be just as distressed or more distressed. All of us worked with profoundly people in profound pain. To just stop exceptionalizing people because they identify as trans, actually, or because it's gender related, and just reconnect to the humanity of all of this. And when you do that, you take we have to take the gender aspect seriously. That's what they're bringing. But when you just look at the distress, well, that's our bread and butter, right? It's what we do all the time, and we will have developed skills for tolerating and containing and comforting in an appropriate way. From all the other client work that we've done across our lives.
I mean, do we? do people really learn to tolerate and contain and just bear with distress? Because
Well, I mean, yeah, sorry.
the model to me seems to be people are in distress. It's my job to alleviate their distress.
Yeah, well, there's been a shift, I guess, hasn't there, over the years in the training. And one thing that I notice in the UK is that certainly in clinical psychology, we're not great at dealing with projective identification and understanding why we might be feeling complicated relationships about and towards clients. Something we really need to be aware of in this area. But also we're really poor at tolerating being the hated object, so to speak. We're really not good at it. We, like most people, are drawn to these sorts of professions because they want to help, and and actually a lot of the training I'm seeing today isn't actually even talking about how do you have the tough conversation? How do you disagree with a client? How do you bear it when they absolutely hate you and they bring this up to you week after week after week? And these sort of skills aren't, who really comes into therapy to do that? I think that our social work colleagues in the UK are much better at that than we are in clinical psychology.
This really struck me when I first got into this work with trans-identified kids, that the suicidality issue, that suicide seemed to immediately lead to a need to urgently administer medical interventions. And it's like, what? Like, we deal with suicidality every day. At least, I don't know, I have many of my patients over many, many years, and I don't immediately put them on a medication or have them admitted to a hospital or whatever. Like, we kind of find ways to think about it and help the person manage whatever is generating the distress that leads to suicidality. But like you said, the exceptionalization that happens with trans kids is, it's like, I don't know, there's something going on around no longer being able to hold that distress and work with it.
Which I think is, in a way, prejudice. We're treating them differently from every other client. And speaking to that, Roberto, about the suicide, it's not just we therapists who've lost like our way of treating people normally, but in no other medical field would suicidality suggest that somebody is in a place to make informed consent about life-altering medicine. So sometimes in my training, I say, look, if somebody's suicidal, they need psychiatry. They don't need endocrinology. They may go there in the future, but right now they are not ready, to make those decisions. But we've lost all of that. Yeah.
It's so heavy. And I mean, I don't want to, this is not really about the executive orders, but that also just makes me think of how many young people have also kind of bought a narrative. They've almost internalized a narrative that they've learned about from friends or the internet that says, if you want this, claim suicidality. And actually, the line is quite blurry. Like, I've certainly worked with young people who I think they're seriously at risk of serious self-harm and or suicide attempts, but then many others make a claim like that at school or in a specific context, and it's taken quite literally without really thoroughly assessing the intent or the motives or any of those things. And then perhaps those kids are medicated. And I mean, there's just so many downstream effects of what happens when clinicians lose their bearing in the ability to slow down and really try and understand what's going on for a patient. It cascades a series of choices that really can derail a young person's ability to heal from this momentary crisis. So it just made me think about that.
But the whole system, it's not just the therapist, it's the whole system. And I think, I mean, we've got to also think about the medical systems that we're all operating in and the reality of the resources.